Next, we have Dr. Elliot Stephenson from Allina Health, Minneapolis Heart Institute, and he will be talking about abdominal aortic aneurysm management. Dr. Elliot Stephenson is a vascular and endovascular surgeon at Allina Health, Minneapolis Heart Institute in Minneapolis. He grew up in Minneapolis and attended Washington University in St. Louis for his undergraduate degree and the University of Minnesota Medical School. He completed his general surgery residency and vascular surgery fellowships at Oregon Health and Sciences University in Portland. His professional interests in vascular surgery embrace a broad spectrum of systems, and we are pleased that aneurysms and dissections are amongst that to have his expert eye and hand applied. Thank you, Dr. Stephenson, for your continued efforts for your patients and sharing your treatment process with us today. Welcome.
Thank you. It just clicks through. Okay. Sorry. My name is Elliot Stephenson. I'm a vascular surgeon at Abbott Northwestern and Minneapolis Heart Institute. I don't have any financial disclosures for this talk, although I do participate in a number of different endovascular trials for aneurysm repair. But I'm not going to, this is all just very generic, no specific. There are a lot of different companies that make grafts, but we won't talk about any specific ones. Fortunately, I think there's been a lot of talk about the aorta today so far, and some of the things I won't have to cover as much, but I'm going to focus mostly on the abdominal portion of the aorta, talk a little about what aneurysms are, and some talk about screening, as I think that's very important for abdominal aortic aneurysm, and then specifically how we manage them. And that's about 90 pages in our sort of manual of vascular surgery, so I'll try to go quickly. Aneurysms are just one, any time that normal artery is dilated 1 to 0.5 times. So in the way we normally characterize the abdominal aorta is having a sort of defined diameter of 2 centimeters. So any aorta that is in the abdomen is greater than 3 centimeters is going to be an abdominal aortic aneurysm. And then we mainly define them in relation to the renal arteries, which are unfortunately, the arteries coming off. So the iliac arteries are the bottom arteries, and then the next arteries coming up are going to be the renal arteries going to the kidneys. And mainly focusing today on infrarenal abdominal aortic aneurysm, which is the most common, but basically the entire aorta can have disease, but we really characterize where the aortic aneurysm is based on the renal arteries, because that really changes how we manage them. And so I think we've covered some of this, but the most concerning issue with aortic aneurysms is rupture. And unfortunately, that's often the first symptom that patients may have, and unfortunately, that's frequently a fatal problem. The CT scan on to the right shows a sort of large amount of blood behind the kidney and by the aorta. That's consistent with that'd be very concerning for an aortic rupture. There's other complications. They can also cause clotting issues. There's either the aortic itself can completely clot off, which can then cause not enough blood flow to the legs or even to the kidney arteries, as well as there's frequently clot that is in the wall of the aneurysm, and that can break loose and travel down and occlude vessels in the leg, like on the angiogram. I think it's been kind of talked about, but the main, really age, smoking, and family history are the main risk factors for abdominal aortic aneurysm, as well as there's a strong male predominance. Atherosclerosis, hypertension, trauma, and dissections are also a part. Screening is really critical because, again, unfortunately, if without screening, frequently the first symptom of someone to have is a rupture. And screening really, is fairly easy to do. It can be done with ultrasound. The current recommendations are, at least from the United States Preventative Services, is for all men between 65 and 75 who either have smoked 100 cigarettes in their life or who have a first-degree relative with an abdominal aortic aneurysm should get screened. And there's really insufficient evidence for screening for women, but this is a real problem because women get aneurysms, and sometimes patients may be 76 and they didn't get screening. And so I think screening really should be done for anybody with a first-degree relative. That would be either a parent, sibling, or child. And then again, I think, and that really should be men or women. And then again, I think men who smoke cigarettes are at significant risk, so I tend to screen up to about 80. Above 80, I often don't screen for just because life expectancy. And screening is really ultrasound is really great for screening. However, it's really not sufficient for really defining the anatomy well for management. And so I think the best initial way to find aneurysms is with ultrasound, but CT angiogram is really going to be the best option for defining the anatomy and sort of defining the management. And this is just a CT scans. Used to be CAT scans. Now we really have pretty nice software capabilities, which allows us to kind of look at these images in multiple different dimensions. There's some even more complicated three-dimensional and sort of cross-sectional central lining techniques that can be done. But this is just a video of what we're looking at. This is the aorta, and I don't think I can stop it, sorry. But this is just a relatively straightforward-looking aortic aneurysm of approximately 6 centimeters. So the management is really based on size. Size is the best surrogate we have for rupture risk. And so 5.5 centimeters is the standard recommendation for repair for men. Unfortunately, this is really well studied in men. There's basically 3 major trials showing no benefit to early repair, but the problem with these trials is they were almost entirely a male cohort. We do know that women tend to have risk for rupture at smaller sizes. I tend to think that the aorta is probably smaller in size to start with, so 5 centimeters is kind of the standard cutoff for repair of an infrarenal aortic aneurysm in a woman. We also look at growth rate. So if the aneurysm is growing fast, that's concerning for possible rupture. And then symptoms. Again, this is a relatively uncommon finding, but if someone has severe abdominal pain, severe back pain, and we don't have another good reason for why they have this pain, and again, it's usually new pain, unlike anything they've ever had, that's very concerning that this aneurysm, which may have been stable for many years, is now sort of becoming inflamed and may rupture. So for small aneurysms, really just continued surveillance, and I think Ken talked about avoiding fluoroquinolone antibiotics, smoking cessation. And really the risk of rupture for a small aneurysm is really pretty low, and it does increase as the size gets bigger, but again, it's not, I think some of the old papers had said 50% rupture rate. Again, most of the more modern is the annual rupture rate, even in a large aneurysm is probably, 10 to 20% at most. Getting in just briefly to this different. There's really sort of 2 different techniques once an aneurysm has reached sufficient size to recommend intervention. And again, this is kind of really looking at the unruptured elective aneurysm. There's open surgery, and then there's endovascular surgery. And again, the open surgery is making a relatively large incision and replacing the segment of aorta that's dilated. And then the alternative, and this is more and more the most common way this is fixed in the United States, is with an endovascular repair, or EVAR. And this can be done, this is done by deploying the device through the arteries. Usually access is gained in the femoral arteries. It can be done in other arteries, but the femoral arteries tend to be the best option. And again, a much smaller remote access. And this is sort of just briefly the steps of open surgery, incision. There's a midline incision is one option, and then there's also something called the retroperitoneal incision. It just depends a little bit on the anatomy of the aneurysm and what needs to be repaired. Once the abdomen's opened, the retroperitoneum's entered, and bowel contents are moved to the right, and this allows you to basically expose the aorta and get control of the vessels. Then you basically open the aneurysm sac just you want to clamp the arteries very carefully first, but then you open the aneurysm, and there's usually back bleeding from vessels, which are oversewn, and then the graft is sutured in place. This would be what we call a tube graft, where it's just a straight tube, but sometimes it's a bifurcated graft, like a pair of pants coming down onto the iliac arteries. And then the graft is, the aneurysm flows over the graft to protect it, and then this is basically what the incision looks like for open repair. There's a fair number of different acute complications, bleeding, respiratory issues, cardiac issues, and so it's a fairly significant operation. Frequently, there's about a 7-day hospital course, often a couple days in the ICU following this procedure. And then long-term, there's some risk of the aneurysms above or below the repair becoming aneurysmal, also risk of incisional hernia, and then there's some rare complications that can occur with either infection or when the graft becomes somewhat in contact with the intestines. And so the endovascular repair is really the more common way these are repaired in the United States. Again, it's probably somewhere above 80% at this point in time. And again, the main benefit's really the minimally invasive nature of it. The steps for this is really to gain access to the vessels. And again, this can be done with a small incision or with a little bit larger incision, but it's done in the groin. And then basically we put in fairly large sheaths. These sheaths are frequently at least 4 to 5 millimeters in diameter, so relatively large tubes going into the arteries. And then this is an angiogram to identify the landing zone. The angiogram shows renal arteries. They're coming off at different locations. The one going to the screen right is give you the patient's left, and then the right renal is the lower of the two, and that's the one where the graft is going to seal against, or just below. So then this is sort of a cartoon. Basically, once you deploy this graft, it's basically a self-expanding graft, and it opens once you remove a constraining mechanism. So there's different constraining mechanisms, but you basically unsheath the constraining mechanism to allow the thing to open up, and then you have to gain access. This was deployed through the patient's right side, and then you have to get from the left side through that other pant leg to what's called the gate, and then you basically measure and deploy and extend if needed. Lastly, we put a balloon in to seal the proximal and distal seal zones as well as the overlaps, and then take a picture. And then just to kind of highlight how this is done in practice, this is an 85-year-old female with a relatively large abdominal aneurysm. It was measuring just under 8 centimeters. It was a new diagnosis. She had a pulsatile mass on exam because she's fairly small. So you can easily feel this pulsating mass. The main concern really is the angulation of the aorta. Instead of being a nice straight tube with 2 iliac arteries coming off the bottom, it's very angulated, which is not uncommon. Given her age, and she has some emphysema as well as heart disease, did not think she'd be a candidate for an open repair. And so again, some patients are not also candidates for endovascular repair, but based on this was really her main option. She has a proximal seal zone, which is adequate for length. It's approximately 20 millimeters. Usually we want at least 10 millimeters, but often the more seal zone you can get, the better. The iliacs have adequate, they're patent, and they're of adequate size for a good seal, no aneurysms. And then the femoral arteries, she has previous hip replacements, but the femoral arteries are open and adequate for access. And the issue really is the tortuosity of her iliacs and her aorta. And so all of the endovascular procedures are done under fluoroscopy. So access is gained and wires are placed up, and then everything else is done with pictures, X-ray pictures. And so this is angiogram we take with to kind of identify the seal zone where the kidney arteries are coming off. The graft is in place. We knew the size we needed, so but this is a little on the high side. So then we deploy the graft, and you can see there's a little bit of the flowering metal, and there's some markers on it to kind of help show you where the graft is. Unfortunately, it's retracted somewhat back from the kidney arteries. It's not retracted a lot back, but there's probably about 4 millimeters or so where it's sort of subsided, and that's not uncommon because the heart's pumping and there's blood rushing down the aorta all while you're doing this. We just marked out the internal iliac arteries. That's the right internal iliac artery. Then the left is marked out, and the graft's deployed. So hopefully you're done at this point. Unfortunately, the completion angiogram shows that we didn't get a proximal seal. There's some kind of gray staining to the left of the graft, and that is consistent with what I say is a large type 1 endoleak. And so basically that proximal portion didn't get a good seal. And so that, again, I knew the graft was a little low, so you can place a little cuff and extend, and then that endoleak had resolved. Unfortunately, the completion at the bottom shows there's actually a leak from the bottom as well. And that's, again, you see there's contrast that's just outside the limits of the graft. And that's really what endoleaks are, is where the flow is still getting in, so there's the aorta is still intact, and there's no blood leaking out of the arteries. However, there's still perfusion getting into the aneurysm sac, and so endoleaks are the main issue we have with endovascular repair. The one I first showed was a type 1. Those are where either the seal at the bottom or the top is not adequate, and those really need to be repaired right away. Type 2 endoleaks are where there's still flow coming in through the other blood vessels that come off the aorta. There's segmental arteries in the abdomen. They're blood vessels going to the lumbar, and as well as the inferior mesenteric artery, which comes off. And these are variably patent, and they sometimes can cause persistent filling. And then lastly, the type 3 endoleak is if there's the overlap or it didn't seal, or if there's a hole in the graft. And this is actually what I found after taking some different pictures in different angles. There's a little hole right in the left iliac limb. So put another piece in, and it's resolved. Endovascular complications really are, the main one is endoleaks. There's about 25% of patients who have an endovascular repair are going to need reintervention for these endoleaks. Endoleaks are even more common. However, not all of them need reintervention. There's also some access complications, and like open surgery, anytime you implant something, there's risk of infection. And sort of just to summarize, open repair versus endovascular repair, there's really not a great, clear, better option. Endovascular repair is associated with a much easier recovery. Frequently, the patients are in the hospital just a day or two. They're back doing normal activities in a week or two. Open surgery is really in the hospital a week and probably at least 3 months before they feel back to how they feel before surgery. So it's a pretty extensive recovery. The benefit of the open repair is it's just a more durable repair. We don't have to image them patients as much. So the annual survey. So after an endovascular repair, we get CT scans every year for basically ever following an endovascular repair. Whereas with an open repair, we usually check every 5 years. And so I think in general, sometimes one option is clearly better from anatomy, patient characteristics, in which case I think then it's pretty easy. But a lot of times patients have, there's choices, and I talk to the patients extensively about the choices, and then pick whichever the patient chooses. And this is just the 15-year follow-up of one of the big randomized trials looking at this. And And out at 15 years, the survival curves are very, very much equal. So thank you for your attention. I used to show this picture of Abbott Northwestern. It looked really kind of an idyllic place. That's not what it looks like now, but soon it will be nicer. Thanks.